Morning, good morning.
Good morning, sir.
Neeraj, you are presenting?
Yes, sir, I'm presenting, sir.
Okay, so put your camera on, start.
Good morning, sir.
Morning.
Good morning, sir. Sir, I'll be presenting case history of 48-year-old male, farmer by occupation, resident of Pilibhit, Uttar Pradesh. He presented to us with chief complaints of burning sensation burning sensation in the upper abdomen since 2 months, with vomiting episodes since 20 days. Patient was apparently well 2 months back when he developed upper abdominal burning sensation with occasional reflex symptoms. This sensation lasted throughout the day with increase in intensity after the meals. It was associated with the upper abdominal fullness after the meals. Since last 20 days, he has started having vomiting episodes, which was copious in amount, non-bilious in nature. It occurred 3 to 4 hours after the solid meal and contained partially digested food particles. These vomiting episodes were associated mostly with a solid meal, but the patient told he was able to tolerate liquid diet. After liquid diet, he was not having any vomiting episodes. Upper abdominal fullness usually was resolved after vomiting episodes. He also gave history of loss of weight of around 5 kg in last 2 months, and he also complained of loss of appetite. There is no history of reflux regurgitation or epigastric burning in the past. There was no associated difficulty in swallowing. There is no history of early satiety. No history of abdominal pain, distension, except for upper abdominal fullness. There is no history of hematemesis or melena. There is no history of postural dizziness, syncope, fatigue, or shortness of breath. There is no history of blood transfusion. There is no history of respiratory distress or hemoptysis, back pain or bony pain. No history of corrosive ingestion, and no history of chronic NSAID or PPI use. For these symptoms, he was evaluated, and upper GI endoscopy and biopsy was done 10 days back. One tube was inserted through the nose, and it was advised to take feeds through this tube. In the past history, there is no known. He did not have any comorbidities, and there is no history of prolonged indication of prolonged medication intake. No history of any surgery in the past. In family history, there is no history of similar illness in the family. He is non-smoker, non-tobacco user, and occasional alcoholic. Last alcohol consumption was 3 months back, around 40 ml he took. Appetite was reduced since last around 1 month, and he is on tube feed since last 10 days. His bladder and bowel habits are normal, and sleep cycle is regular. To summarize, 48-year-old gentleman, non-smoker, occasional alcoholic, without any comorbidities, presented with 2 months history of new onset dyspeptic symptoms, with the postprandial upper abdominal fullness, with large volume non-bilious vomiting episodes since 20 days, without any history of upper GI bleed. Currently, he's on tube feeds.
So just 2 points. As far as I'm concerned, I'm fine with it, but some examiners are very particular that when you are presenting history, you present the history in patient's terms. So reflux is a technical term. I don't expect that a farmer from Uttar Pradesh would mention that he's having reflux. So it is better to use the lay terms. So it is better to say regurgitation. Some examiners would interrupt you on that. Second, there is nothing called occasional alcoholic. Alcoholic is an alcoholic. One who consumes alcohol occasionally is called a social drinker. So there is a WHO definition of alcoholic which specifies a certain amount of absolute alcohol, so many days in a week for so many months or so many years. Check on that. I don't remember it exactly, but somebody who takes alcohol on and off, don't call him an alcoholic. Okay, alcoholic is a person who has been taking a significant amount of alcohol most days of the week for a reasonable period of time, and who would take alcohol even if he is alone at home almost every day, kind of thing. So there's no term called occasional alcoholic.
Okay, sir.
So what do you make out of this history?
Sir, 48-year-old gentleman, he's
I didn't ask how old is he. I asked what do you make out of this history. Don't repeat what you have already said.
Sorry, sir. Uh, so a patient is having features of gastric outlet obstruction, most probably because of malignant etiology, sir.
Yeah.
My
So
most probable
right.
diagnosis is
Your
sorry.
answer should be that these symptoms are suggestive of gastric outlet obstruction, and I think it is malignant gastric outlet obstruction. Okay. So, what is typical of gastric outlet obstruction here, and what is not there?
Sir, typical of gastric outlet obstruction is non-bilious vomiting episodes, sir, which are with the postprandial fullness, he complained, and relief of postprandial fullness after vomiting episodes, sir. So, vomiting episodes, he did not mention about the projectile nature, but he's having vomiting containing retained food particles, sir.
So, non bilious vomiting, partly digested or undigested food,
Yes, sir.
postprandial fullness, which is relieved by vomiting, these are points in favor of gastric outlet obstruction. The other points which could have been there, and maybe you could have asked, that the timing of vomiting. In patients with gastric outlet obstruction, vomiting usually occurs at the end of the day.
Yes, sir.
When they have taken both the meals, both the major meals, number one, although not necessary, it can happen anytime. Second is, as you rightly mentioned, projectile vomiting. So these are all very characteristic features which would establish that this is gastric outlet obstruction. Okay?
Yes, sir.
Fine.
May I interrupt, sir?
Yes, please.
Yeah. It is important to differentiate whether it's only food that's being vomited or all liquids and everything that he's taking. Is
Sir,
it
I mentioned,
absolute obstruction or it is relative to only solid food material?
sir, it is relative to solid foods only. I have mentioned, sir.
Yeah. If it is
Patient,
to solids only, was there a precipitating event? Did he take meat or something like a bolus obstruction had occurred and then he started vomiting?
no, sir, no, sir.
Nothing like that.
It was not bolus.
Yeah. So you didn't mention anything about his urine output, whether it was regular or not. You did not mention
His bladder and bowel habits are normal, sir.
whether he is feeling very thirsty is important.
Okay, sir.
How much weight he has lost, that is
Sir,
important.
lost around 5 kg in 2 months, sir.
Okay, so is this what could be the causes for this loss of weight in 2 months? What are all the mechanisms by which the loss of weight occurs?
Sir, patient is not tolerating solid diet, sir. Mostly, he's having vomiting episodes, sir. So, because of decreased intake, this weight loss is happening, and other is malignant etiology, which itself is causing cachexia, sir.
You should remember that dehydration also causes significant weight loss.
Yes, sir.
It could be just very dehydrated, and that could cause a weight loss of 1 to 2 kilograms.
Yes, sir.
So
Yeah,
again,
please go on.
when an examiner is asking a question, let him complete. Okay, give a few seconds pause. Make sure that he has stopped asking, and then only you answer. Number one. Number two, Dr. Desai asked you specifically about the urine output, urine volume, which is different from bladder habit. Bladder habit is different. He's asking you about the volume. Okay, so these are two different things. Bladder habit means frequency, dysuria, other symptoms. Okay.
Okay, sir.
Fine. So you said it is malignant gastric outlet obstruction. Why do you say so?
Sir, these dyspeptic symptoms are on short duration. New onset symptoms are there. Patient did not have any prolonged history of dyspepsia or chronic PPI
So
use.
a patient who has short duration of symptoms cannot have a benign disease?
Sir, can have, sir. Acute.
This I have said so many times earlier also. A short history does not exclude a benign disease.
Yes.
A long history may exclude a malignancy. Suppose the patient has symptoms over a year or 2 years, then the chances that it is malignant are less likely. But short history does not exclude malignancy, benign disease. A patient with suppose the patient has gastric outlet obstruction because of peptic ulcer. He vomits one day, he goes to the doctor next day. It doesn't mean that it is not benign, isn't it?
Yes.
So please keep that in mind. Short history usually would not exclude a benign disease. Similarly, in jaundice, the patient has jaundice with sudden right upper abdominal pain. It doesn't mean that every patient has CAGB. The commonest cause of jaundice is still hepatitis. So 15 days history of jaundice does not mean that it is malignant. If you see 100 people with jaundice, most will have hepatitis. So give me some other points to say that this is malignant.
Neeraj,
Yes, sir.
what is dyspepsia?
Dyspepsia is, sir, heartburn sensation, sir. That may be persistent or intermittent, sir.
Dyspepsia is defined as abdominal pain in the epigastrium with multiple causes. It is discomfort in the epigastrium. Reflux is not dyspepsia. That is reflux dyspepsia, it is called. It's not called dyspepsia.
Okay, sir.
Yeah. So why do you say it is malignant gastric outlet obstruction?
Sir, patient is also having loss of weight and loss of appetite along with the new onset dyspeptic symptoms, sir.
Which is more important?
So loss of appetite here is more important, sir.
Yeah, because even with benign gastric outlet obstruction, the patient will lose weight.
Yes,
You should remember that there are few benign conditions, including benign dysphagia, benign gastric outlet obstruction, intestinal obstruction, chronic pancreatitis. These are benign conditions where patients may lose a significant amount of weight, other than tuberculosis, which can cause both anorexia and weight loss. But there are certain benign conditions where patient may not have loss of appetite, but will lose weight because of poor intake or poor absorption. So loss of appetite is more important. Also, you need to differentiate between loss of appetite and patient having appetite but not feel like eating. Not feel like eating is when food precipitates pain. For example, patient with gastric ulcer or mesenteric ischemia, chronic mesenteric ischemia. These patients, they are afraid of eating, although they have appetite, but they don't eat because they know that the food is going to precipitate an episode of pain. Okay, so one has to differentiate between loss of appetite and loss of intake or fear of taking food. Okay, let's carry on.
Sir, on examination, patient is average built with the nasal tube in situ, sir. Sir, patient is average built with the nasal tube in situ. He's alert, conscious, cooperative, and well-oriented to time, place, and person. His ECOG performance status is 1. BMI of 24.86 kilogram per meter square with height of 167 centimeter and 169 centimeter and weight of 71 kg. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Patient is well hydrated. Pulse rate of 84 per minute and BP of 116 by 70 mmHg in right arm supine position. Respiratory rate of around 14 per minute and is afebrile. Breath holding time is 30 seconds. In oral cavity examination, oral hygiene is good. Adequate mouth opening is there. Oral mucosa and tongue is moist. Normal tongue movements with no mucosal lesions. There was no palpable left supraclavicular or axillary lymphadenopathy.
Neeraj, it's also important to mention whether he's on IV supplementation. When you're examining the patient at the bedside, is there an IV fluid bottle connected to him? Because that could explain why he's well hydrated. Otherwise, the history of gastric outlet obstruction, significant weight loss, and well hydration doesn't go hand in hand.
Okay, sir. So actually, he's on tube feed since 10 days, sir.
So he's tolerating liquids.
Sir, tube feeding is tolerating, sir.
Yeah, tube feeding is nasogastric or nasojejunal?
Sir, in this case, most probably it is nasojejunal, sir.
Yeah, please go on.
Sir, is my slide visible, sir?
Yes.
Sir, on abdominal examination, abdomen is flat without any flank fullness. Umbilicus is centrally placed, inverted without any nodularity. There is no visible lump, scar, sinuses, dilated veins, pulsation, or peristalsis. All quadrants are moving correspondingly with respiration. Hernial orifices are intact with no cough impulse visible, and no renal angle fullness was noticed. On palpation, abdomen is soft, non-tender. There was no palpable lump or nodularity. No organomegaly was palpable. And hernial orifices, there was no palpable cough impulse, and renal angles were free. On percussion, no free fluid, no evidence of free fluid noticed. Liver dullness was started at fifth intercostal space, like liver span of 12 centimeter in right mid-clavicular line, and rest of the abdomen is tympanic. Ausculto percussion test was negative. Auscultation, there was normal bowel sounds heard. No succussion splash was heard. In DRE, perianal skin was normal, no skin tag, fissure, fistula, or external hemorrhage noticed. Anal tone was normal. There was no growth or nodule palpable on parectal examination, and finger was stained with feces. There was no blood staining.
Yeah, you mentioned ausculto percussion is negative. There's nothing like a negative ausculto percussion test. You have to mention where you got the border, or you couldn't get a border. In a patient with gastric outlet obstruction, if he has a nasogastric tube and his stomach has been emptied, ausculto percussion will show a very high border. It won't show a dilated stomach. So don't say negative ausculto percussion.
Sir, respiratory examination, trachea was centrally placed. Bilateral respiratory movements were equal. Bilateral lung fields are resident on percussion, and normal vesicular breath sounds were heard. No added sounds were heard. On CVS examination, S1, S2 were heard, and there was no added sounds. CNS, there was no focal neurological deficit. Sir. To summarize, a 48-year-old gentleman, non-smoker, social alcoholic, without any comorbidities, with the 2 months history of new onset dyspeptic symptoms with features of gastric outlet obstruction since 20 days, without any history of upper GI bleeding, currently on NG feeds. On examination, he is average built, moderately nourished, with BMI of 24.86 kg per meter square, with nasal tube in situ. Rest of the examination was unremarkable, sir. So after examination, my differentials are the same, sir.
So the other differentials, are you seriously considering them, or you mentioned them only for the sake of mentioning?
Sir, patient can have peptic ulcer induced stricture as well. Acute peptic ulcer can give this picture as well. Sir, carcinoma GE junction involving the continuous distal involvement can give similar features, but patient is not having any features of dysphagia, sir. So that is less likely possibility, sir. But still, patient may be having carcinoma GE junction with continuous involvement of the distal entropyloric region, sir. Sir, gastric cyst mostly was present like this, sir.
The moment you say carcinoma GE junction, you should not make a clinical diagnosis of a GE junction malignancy if there is no dysphagia. Here, the predominant presentation is gastric outlet obstruction. So the clinical diagnosis would still be lesion at the entropyloric region. Whether it has come from above, that is different. But I don't think clinically you should say that.
Okay.
Peptic ulcer induced stricture, I can still accept that his loss of appetite is basically that he knows that if he eats, he will vomit. So that is what he is describing as loss of appetite. It is possible that a patient may not have previous history to suggest peptic ulcer disease and can present for the first time with features suggestive of gastric outlet obstruction. It is also possible that in an acute exacerbation of a peptic ulcer, there may be inflammatory edema which can cause gastric outlet obstruction. So that I would accept. But carcinoma GE junction in a situation like this, I don't think I would agree. Next.
Okay, sir. Sir, gastric just mostly won't present, usually present with a palpable mass or with the bleeding episode, sir, with features of early satiety maybe. But gastric cyst can also cause gastric outlet obstruction, sir.
Can, but again, clinically, you would not make a diagnosis of gastric cyst in a patient like this. Gastric cyst, commonest presentation would be bleed, a palpable lump, or in a patient who has postprandial fullness, large just which is occupying most of the lumen of the stomach. So a patient who's presenting with gastric outlet obstruction, I don't think you should make a diagnosis of gastric chest. So what is the differential diagnosis of a patient presenting with gastric outlet obstruction theoretically?
Sir, theoretically, patient can be having a benign condition that may be peptic stricture induced gastric outlet obstruction or corrosive induced gastric outlet obstruction, sir. And malignancy, patient can be having carcinoma stomach, carcinoma of pancreas infiltrating into the stomach, sir, or carcinoma of the gallbladder infiltrating the duodenum or enterophallic region, sir. Patient can be having sir, patient can have had chronic pancreatitis and pseudocyst that may be causing compression, sir, external compression, sir.
So that would go into the benign group. So chronic pancreatitis, is it necessary to have a pseudocyst to have gastric outlet obstruction? Chronic pancreatitis per se cannot?
The chronic pancreatitis per se can also give features of gastric outlet obstruction.
It can. Duodenal stricture, duodenal fibrosis, depending on whether it is pre-papillary or post-papillary, the nature of vomitus would be different. But anything which is even D2 obstruction is described as gastric outlet obstruction, duodenal obstruction. Although semantically you may say that you would like to call it different. So amongst the malignancies, yes, CA stomach, but other malignancies, what is the order that you would put in a patient like this?
Sir, no, patient did not have any history of pain, but still pancreatic head malignancy and gallbladder malignancy can cause features
of more likely in this case. Suppose I say it is not CA stomach.
Yes.
In this patient, which is the more likely malignancy if it is not stomach?
Sir, pancreatic head is more likely, sir.
Why?
Sir, it is not necessary, but gallbladder cancer infiltrating into the duodenum will also be presenting with jaundice, sir.
Which is less likely to be associated with jaundice, pancreas or gallbladder? Because here there is no jaundice. Yes, so sir. We are talking of GOO without SOJ. If it is GOO with SOJ, it is very clear. It is CA head pancreas.
Yes, sir.
So CA head pancreas causing gastric outlet obstruction but not causing jaundice is less likely as opposed to CAGB. Because if the tumor is at the fundus or body and it is infiltrating the duodenum, it will present with gastric outlet obstruction but no jaundice. Only neck tumor will have jaundice. Also, you should at some stage mention a duodenal malignancy. Yeah. Malignancy in the duodenum will also present with features like this, especially if it is in the D1 or D2 pre-papillary, because it is a non-bilious vomiting. But suppose I say that there is a tumor in the pancreas, which part is it more likely?
In this context, body lesion is more likely as compared to the pancreas.
So if there is a tumor in the body of the pancreas, what will it cause obstruction of? It will cause obstruction where? If the tumor is in the body, it will cause B3 obstruction, isn't it? On one side, it will involve the stomach. On the other side, it will involve the duodenum. Stomach involvement, body of the stomach involvement will not cause obstruction. It may cause bleeding, but it will not cause obstruction. So if you have duodenal obstruction and post-papillary duodenal, but in that case, the vomiting should have been bilious. Same is true of uncinate process. A tumor in the uncinate process can cause duodenal obstruction, but no jaundice, because the tumor is below the level of the ampulla. It is in the lower part of the head of pancreas. But then in that case, in both these cases, the vomitus will be bilious rather than non-bilious. So non-bilious vomiting means that either the tumor is in the stomach or it is in the first or the proximal half of the second part of duodenum, or it is in the fundus and body of the gallbladder involving the first part of duodenum. And very rarely, it could be head pancreas, which is going mainly into duodenum but has not caused biliary obstruction. Okay. So this patient comes to you in the OPD or in the emergency. What will you do?
Sir, I will first resuscitate the patient. I'll start him on IV fluid, sir. with saline. I will look for his complete blood picture along with the electrolytes.
What is the clinical method of diagnosing dehydration and following it up? Its
Sir,
correction.
skin turgor we look for, sir.
Where?
Sir, on the dorsal aspect, sir.
In an elderly man, would you look on the dorsal aspect of the hand?
No, sir, not on the dorsal aspect.
Where would you look? Which area is not affected by wrinkling and old age?
Sir, chest won't be affected with wrinkling.
What test? You have to examine the forehead. Forehead is the part, and also you have to see the moistness of the tongue. But if he is a mouth breather, it can be dry and it can be coated in gastric outlet obstruction. So if you see a coated tongue, you have to mention it because candidial secondary infection is seen in gastric outlet obstruction. And candidial infection of the GI tract can present with vomiting and dyspepsia. Yeah, go on, please.
Sir, along with the blood workup, after resuscitation, then I would look for simultaneously. I will look for the previous record because patient gave history of upper GI endoscopy and biopsy, sir.
You didn't mention an important. Suppose this patient came to you before the nasojejunal tube was introduced.
Sir, before that, I would put nasogastric tube, sir, and I will drain the gastric content, sir.
Any important blood investigation which you did not mention in a
Sir,
patient?
VBG, I will look for, sir.
Yeah, very important. You have to look at the metabolic profile. It is not only electrolytes. You have to look at the acid-base status also. So in these patients, other than looking for evidence of dehydration, you have to look at their metabolic profiles. What do you expect to find? Suppose he came to you without any support before the tube was placed. What did you expect to find?
Patient will have, sir, hyponatremic, hypokalemic metabolic alkalosis, sir. Hypochloremic metabolic alkalosis, sir. With paradoxical aciduria. With paradoxical aciduria, sir.
What is the mechanism of paradoxical aciduria?
Sir, as the patient is having hypokalemia, sir, so at the renal tubules level, sir, there will be exchange of potassium with the hydrogen ion, sir. So at that level, potassium is conserved and hydrogen ion is excreted, sir. So that's why patient will be having paradoxical aciduria, sir.
So what is the effect of volume contraction on the kidney?
Sir, patient will body will release ANP, sir. Sorry, sir, I'm not clear about that. I'll read it out.
No, basically it is that the patient is dehydrated, his blood volume will come down, osmoreceptors will be triggered because his basal osmolality will increase because gastric fluid is acidic and it is normal saline basically. So he'll be losing a lot of fluid and sodium. So he will have concentration of the blood and that results in osmoreceptors being triggered. Also fall in volume of GFR, fall in creatinine clearance. So you have to look at renal function. You forgot to mention catheterization of the patient. That is, of course, depends on whether the patient has severe dehydration or not. If he has severe dehydration, you should catheterize. Otherwise, if the patient is intelligent and can catch all urine outputs, then you can monitor the urine output and allow the patient to just pass urine into a urinal. The reason is if you catheterize, the chance of introducing infection is high. That's why we would like to introduce it as late as possible. But most examiners would expect you to say that I'm going to put a nasogastric tube and give a wash, and I'm going to put a catheter.
And this is a very favorite theory question. So all of you have to read and you should be familiar with the metabolic derangements in a patient with prolonged gastric outlet obstruction. Okay. So you said Ryle's tube. Why do you want to place a Ryle's tube? He's vomiting. He's bringing out everything.
Sir, we need to put Ryle's tube so that patient will not be vomiting. After that, we will drain the gastric content. We will give a thorough lavage of the stomach, and then after that we will be able to do upper GI endoscopy, sir, in such patients, sir.
So the placement of the Riles tube and lavage is important more from planning the upper GI endoscopy, because at that time, if there is a significant residue in the stomach, because of the passage of the scope as a reflex, the patient may have a large vomitus and can aspirate. So it's very important to prepare these stomachs, and sometimes it may take not hours but days, 1 or 2 days to prepare the stomach. And same holds true when you want to do an endoscopy in a patient with achalasia cardia also. It's very important to prepare. While we were discussing the differential diagnosis, we forgot to consider lymphoma. That is another possibility, especially if the patient is young, and if as we investigate, the endoscopy shows normal mucosa and repeated biopsies are normal, and imaging shows diffuse circumferential thickening of the wall of the stomach or duodenum. These are situations where, in any situation where it is esophagus, stomach, or rectum, you should start thinking of lymphoma. Young patient, normal endoscopy, repeated biopsy is negative, and diffuse thickening of the wall on imaging. These are pointers towards the possibility of a lymphoma. Okay, let's go. Let's see the endoscopy. Anything here? Yes.
Sir, in blood workup, sir, patient's ALB is slightly raised, sir. Apart from that, everything else is normal, sir. With his potassium is 3.9, sir. Sodium is 139, and chloride of 105, sir. Rest are within normal limits, sir.
His PCV is not mentioned, and hemoglobin is 15.6, which is rather high in a patient with gastric cancer. So this could be another marker of dehydration. So PCV also has to be done. That will give you some idea.
Actually, in a patient like this, when you mention blood investigations, rather than saying I will do a routine blood workup, you should specifically say hemoglobin, PCV, hematocrit, electrolytes, arterial blood gases, renal functions, and if it is prolonged history, then nutritional status, albumin. So you should be more specific in your answer.
Neeraj, in a dehydrated patient, what are the dangers of a nasojejunal tube feeding?
Sir,
I assume you're not feeding him milk, you are feeding him a prepared solution.
Yes, sir. We are feeding him a prepared solution. So at times patients develop diarrhea after giving nasojejunal feed, sir. So his dehydration will further worsen.
What else? What is the effect of osmolality, high osmolar fluids in the GI tract?
Sir, high osmolar fluid in the GI tract will cause sifting of fluid in the GI lumen, sir. So that will further worsen the hydration status, sir.
It can also cause bowel necrosis. It has an effect on the vasculature, and mucosal ischemia can occur, and you can get gangrene of the bowel if you give very high osmolality fluids very early in the resuscitation. So it's a good idea to resuscitate the patients with fluids and then get because anyway you will be waiting 2 or 3 days before you do the endoscopy to place the nasojejunal tube.
Yes, sir.
What is the role of stenting in gastric outlet obstruction?
Sir, if we are considering for palliative options, then we can go for stenting, sir. Or if we are considering for perioperative chemotherapy and patient is unwilling for nasojejunal or feeding jejunostomy, so in that scenario we can place SEMS, sir.
Although I would slightly change the statement that even for a preparatory relief of gastric outlet obstruction, suppose you want to improve the nutritional status of the patient and then take the patient up for surgery, if cost is not a constraint, then that is the best, because it avoids the discomfort of a nasojejunal tube, and it relieves the vomiting also. Nasojejunal tube doesn't relieve the vomiting.
Yes.
It only provides you a portal for feeding. So the ideal treatment, if cost is not a constraint, is a stent which will come out with your specimen, whether you are doing resection or whether it is as a preparation for chemotherapy, or even if it is definitive. So that is today the ideal treatment to relieve gastric outlet obstruction.
Okay, sir.
Okay,
What
let's see
about
the.
what about endoscopic dilatation? In which conditions of gastric outlet obstruction you would use endoscopic dilatation?
Sir, peptic stricture-induced gastric outlet obstruction, we go for endoscopic dilatation, sir. But in case of malignancy, we won't go for, sir, dilatation, sir, because there is
Well,
risk
as
of
I
bleeding
said,
as well
as
as
a
esophagus.
palliative measure, you can use it. Keeping a tube in situ increases the risk of aspiration. So rather than a nasojejunal tube, you just stent it. But stents are expensive. So if it's going to come out with your surgery, that much expense might not be acceptable. But if you have someone like Professor Baijal, he used to make his own stents, which used to be very cheap.
Yeah, let's see the endoscopy report.
Sir, endoscopy was done on 26th of Feb. Esophagus was normal. OG junction was at 40 centimeter. Stomach, there is also proliferative growth extending from the fundus across body involving the antrum. Growth occupying approximately 1/5 of the total area of the stomach and spread along the lesser curvature. Growth causing deformity of the stomach and palatus was significantly narrowed. The scope was passed with some difficulty, and D1 D1 to D4 was normal. 12 French NJ tube was placed in the jejunum under fluoroscopy guidance, sir. Biopsy was taken at the same time, sir.
There is a question from Dr. Jasmeet Singh that can stents be used if the obstruction is at the level of D2? Neeraj.
Sir, at the level of D2, we won't be able to place because that will obstruct the biliopancreatic flow, sir.
That's incorrect, Neeraj. You can stent it, but you need to
don't
do
use a
biliary
covered
stenting
stent.
as well.
You use an uncovered stent, isn't it?
Use an
For
uncovered
this,
stent,
you
and
don't need
also
a
you can
covered stent.
stent the and you can stent the biliary tree and then put in a stent. That's what we use for pancreatic malignancy as palliation. We put a stent in the D2, we put stent into the biliary tree, expanding metal stent, and that relieves both gastric outlet obstruction and it relieves jaundice.
Okay, carry on.
Sir, histopathology showed poorly differentiated adenocarcinoma, sir.
What will you do now?
Sir, I would go for sir. I would go for a chest X-ray and ultrasound abdomen to look for to screen for dissemination, sir. And simultaneously, I will prepare the patient nutritionally, sir.
Okay.
You would do a chest X-ray, but that is only to screen out large metastasis. But if the chest X-ray is normal, you should also mention that I'll do a CT test. It's very important.
So this is a chest X-ray, which is essentially normal, sir. There is no signs of dissemination, gross dissemination in this chest X-ray. There is no pleural effusion. There is no nodule in the lung window, sir. So this is ultrasound abdomen, which is showing circumferential thickening of the palaroduodenal region. Rest of the ultrasound abdomen and pelvis was normal, sir. There was no SOL or there was no free fluid, sir.
Okay, next.
Sir, then I'll proceed with the cross-sectional imaging, sir. CCT thorax, CCT thorax, abdomen, pelvis, sir.
Do we have the film or the report?
Sir, I have the scan, sir. Sir, this is non-contrast CT scan of CT scan with axial view of thorax and thorax, abdomen, and pelvis, sir. So we can see there is tubing in the lumen of esophagus, sir, and on right middle lobe, sir, there is calcified nodule, sir. On non-contrast scan, another calcified nodule is there in right middle lobe, sir. There is no pleural effusion. There is no ascites, and sir, nasojejunal tube seen to be in situ and passing the palatic region. There is thickening noticed in the entropalatic region, sir.
What about lymph nodes?
There is no pelvic free fluid. Sorry, sir. Sir, lymph nodes. I'll comment on contrast scan, sir.
Okay.
Sir, this is contrast CT scan axial view.
And also, Neeraj, I forgot to mention it. Did you mention supraclavicular lymph node and umbilical nodule?
Yes, sir. I mentioned.
Okay.
Sir, in this, there is no ascites. There is no liver as well, sir. And sir, this growth is almost starting from the level of GE junction, sir. This is the starting of umbilical fissure, sir. This is the level of GE junction, and along the lesser curvature, there is significant thickening of the lumens of the wall of the stomach, sir. It is involving. This is continuously extending along the lesser curvature, sir, involving the enteropyloric region. It is also extending towards the greater curvature side in the enteropyloric region, sir. It is reaching up to the pylorus only, sir, not beyond that, sir.
It's extending into D1. What is the importance of extension into D1?
Sir, if there is extension of D1, we need to, sir, our distal margin, we need to take care of, sir.
What about the diagnosis?
Sorry, sir.
What about the diagnosis? Will it still be carcinoma stomach is the first possibility?
Sir, that will change, sir. Likely that will be D1 infiltrating, D1 adenocarcinoma infiltrating the stomach, sir.
I still feel it could be a lymphoma, although they have said poorly differentiated adenocarcinoma. But just on histopathology, sometimes lymphoma can look like poorly differentiated adenocarcinoma, and you need to do some immunohistochemistry tests. The other point which is against a lymphoma here is that they mention an ulceroproliferative growth.
Okay.
In lymphoma, you would just see non-distensibility of the stomach on endoscopy, and mucosa would apparently be normal. But considering the extent of thickening of the wall of the stomach, I would still keep that some of these things are not fitting in with the classical
also, duodenum involvement is an indicator that it is a lymphoma because it is like a watershed region. Carcinoma of the stomach generally does not go beyond the duodenum. It can go, but it's rarer than if it's a lymphoma. So that's an important marker for lymphoma.
It's important. You see, if it is lymphoma, then your treatment plan would be totally different. So it's very important to differentiate between the two. See here, now the axial cut you are showing, there is a diffuse circumferential thickening of the distal body and the antrum of the stomach.
Yes, sir. Sir, along with that, the growth is abutting the liver, sir. Though it is free from the colon and gallbladder, sir. And also there is fat planes with the pancreas looks maintained except at this place, but there is no infiltration at this region as well, sir. Sir, regarding nodal status, sir.
No, you have to describe it. You have to describe it in more detail. That whether one is that you see a fat plane between the growth and the head of the pancreas in every section. Second is whether there is loss of fat plane. Third is whether there is definite infiltration. So you need to show the worst case scenario. Where is the worst case scenario?
Sir, it is abutting the head of pancreas, but fat planes looks maintained, sir. In case it is infiltrated, that is worst case scenario among these, sir.
So as far as I could see, in most sections, you are seeing a fat plane between the growth and the pancreas. Maybe in one or two cuts,
sir,
you are
this
seeing
section only, sir,
there is no fat.
At this section only, there is the abutting, but still looks like fat planes are maintained, sir.
What else?
Sir, regarding nodal status, sir, there is significant perigastric lymphadenopathy, sir. Along with that, there is lymphadenopathy in the left para-aortic region, sir, at this level, sir. And lymph nodes are also seen at the splenic hilum as well, sir.
Those are the celiacs. That is the celiac lymph nodes. What you are calling para-aortic. This is, you can see the diaphragmatic crust, and if you go slightly lower, you can see the celiac trunk coming off.
Yes, sir.
So they are celiac lymph nodes positive. Perigastric is positive. Splenic hilar, can you demonstrate again, please?
Yes, sir. Splenic hilar lymph nodes are there, sir.
And the notes you were showing, they are not para-aortic, they are pre-aortic. That is why Dr. Desai pointed out that they are probably at the origin of the celiac. Para-aortic means that they have to be lateral to the aorta and, more importantly, posterior to the line which bisects the aorta into two. Anything which is anterior to that would be pre-aortic, which could be at the origin of celiac or SMA.
Okay.
Show the splenic hilar nodes.
Sir, these are the splenic hilar nodes, sir.
It's a bit difficult to make out on CT because they could be veins as well with a flow defect. So it's a bit more difficult for splenic hilar.
Okay, sir. Sir, regarding nodularity, sir, I'm able to appreciate this one nodule here, sir.
Yeah, in CA stomach, whenever you see nodes around the stomach, you have to be very careful to try to differentiate, although it may not be possible all times, whether these are really nodes or whether they are nodules in the momentum, even around the stomach. Here, of course, it is at a distance.
And sir, this one is distant, sir. There is nodularity here as well, sir.
Yeah.
Apart from that, sir, regarding this one, I'm not sure this is perigastric lymph node or this one, sir.
The peritoneum seems thickened there.
Yes, sir.
Yeah, right. Good catch.
Sir, then I would go for, sir, bone scan, sir. So this patient is having
Are there some lytic lesions in these?
multiple lytic lesions, sir. Multiple lytic lesions in the vertebra, sir. Sir, in thoracic as well as.
Yes.
Yeah.
Yeah, I think they are.
Why is the body of the vertebra involved in metastasis? Which is the commonest area for metastasis, lamina or body?
Sorry, sir, I'm not sure, sir.
It's the lamina that is more important for metastasis.
Okay.
Body also can get involved in those tumors that spread by blood because it's supplied by the spinal artery directly into the body, so you can get body metastasis. But lamina is more typical of metastasis.
So this patient is having metastatic disease, sir. Metastatic CSTM, sir.
So how would you confirm? What will you do?
Sir, for confirmation, I would go for sir, PET scan. I can go for, but sensitivity PET CT we can go for, sir. But sensitivity is comparatively poorer for carcinoma stomach, sir. For bone lytic bone lesions alone, sir, we can go for bone scan as well, sir.
Yeah, that's much cheaper, much less expensive.
Yes, sir.
So if you are suspecting bone metastasis, and if that is going to change your plan of management, I personally would prefer to do a bone scan and confirm. Bone scan is a very good investigation to say whether these are metastases or not.
Sorry, sir. I also I would like to see the thoracic scan as well, sir. Sir, there is one nodule which we were seeing in the pain scan as well, likely calcified nodule, but still I would check for the enhancement, sir.
Okay, let's move on. Is there anything else in the CT?
No, sir. These are calcified nodules, sir.
So let's say that if there are these bone lesions, then I personally would prefer a bone scan. Suppose those bone lesions were not there, then what would you do?
If bone lesions were not there, I would go for perioperative chemotherapy, sir. And after 4 cycles of perioperative chemotherapy, float force regime, sir. And after 4 cycles of chemotherapy, I will redo the CCT chest, abdomen, and pelvis, sir.
You did not do an endoscopic ultrasound. Why did you not do an endoscopic ultrasound, and what is its importance in defining whether to do a laparoscopic gastrectomy or an open gastrectomy?
Sir, if a patient is having early stage gastric cancer, stage 1, sir, involving the mucosa and submucosa, sir, so then I would go for endoscopic ultrasound, sir. Sir, for laparoscopic gastrectomy part, sir,
It is
if it is early
important to
cancer,
differentiate between T2 and T3 lesions. T3 lesions where the serosa is involved, you cannot do a laparoscopic gastrectomy. You have to give flot and then do laparoscopic gastrectomy. That's why it's important. I agree that in early gastric cancer, to diagnose itself, it's important to differentiate the various types of early gastric cancer. But we rarely see early gastric cancer in our country, so the experience is very poor for us. In fact, in so many years, I haven't seen an early gastric cancer. Gastric cancer.
Your answer should be that endoscopic ultrasound is useful in the early stages of gastric cancer to decide, number one, whether endoscopic management can be done. Number two, whether neoadjuvant chemotherapy is not required. And number three, as Dr. Desai said, whether the case is suitable for a laparoscopic gastrectomy. In patient who has a transmural involvement on imaging, who's presenting with gastric outlet obstruction, where you have perigastric nodes, it is not indicated, it is not required, it is not going to help, and it may not be possible because the scope will not pass through unless you dilate the lesion. So you said neoadjuvant chemotherapy followed by surgery. What about the omental nodules? You didn't address them.
Sir, I would like to take biopsy from the omental nodule before that, sir.
How?
Sir, if possible, ultrasound or CT guidance, sir.
Why not laparoscopy?
Sir, if ultrasound or CT guided is not feasible, then I would go for diagnostic laparoscopy,
For
sir.
omental nodules, ultrasound or CT guided biopsy is not possible. CT guided biopsy is possible for the vertebral lesions. It's possible for the very large nodes.
Okay, sir.
For small
What was the
nodes,
size
again,
of-
it will not be possible.
What was the size of this nodule which we saw? Omental nodule, I think it was about 2 centimeters or less. So it depends on the size. If it is too small, then it will be very difficult. So in the same breath, you should have said, I will see whether it is possible to take it under image guidance. If that is not possible or that is negative, suppose it turns out to be negative or inconclusive, because there is a strong suspicion, you would still do a staging lab. So that staging lab will be before you start neoadjuvant, because if that is positive, then it doesn't remain neoadjuvant. Because of course, that is a separate debate whether you can still or you would still resect in presence of a omental metastasis. But by and large, omental metastasis would contraindicate resection. This recent concept of resection even in presence of oligometastasis. Oligometastasis is small in number, small in size, and close to the primary lesion. So in more and more malignancies, people are now doing it, but that is not the standard of care. Okay. So, and that is why now, if the bony metastases are not there, then even a PET scan becomes important, because if these lesions are lighting up on PET scan, then you will take them as positive, and then probably your overall plan of management will change. Okay. Okay. I think we'll close here. But if you want to continue this into the surgical part, as I have said earlier, please request Dr. Anand to give you another slot where we can start from here. That what is the surgical management, discuss gastrectomy, complications, techniques, types of gastrectomy. Okay.
Okay, sir.
And in the meantime, students, send me a mail, vkkapoor.india@gmail.com. Write stomach in the subject of the mail. So I'll send you both clinical and operative chapters on stomach.
Okay, sir.
Thank you, Rajan. Thank you very much. Thank you, Neeraj.
Thank you, sir. Thank you very much.